June, and we are live on CMAAO International Weekly Meeting. Uh, Finally, it's a lovely weather in Delhi. We have a beautiful rain, and in fact, India has experienced one of the highest rain ever in last many years. So much needed, but much too much for for the day. Today we have a very important session. We are talking about diabetes, insulin therapy. The topic of the discussion is advances in insulin therapy. To speak about it, we have Dr. Abhyudaya Verma. He is joining in from Indore. He's an MBBS and MD doctor from and a general medicine fellow of American College of Endocrinology. He's an associate professor of endocrinology at Index Medical College. He is a consulting endocrinologist, diabetologist in Indore, a super specialty in treating diabetes disease, thyroid disorder, obesity, and hormone disorder problems at Seva Center in Indore. He has done DNB medical specialty training from Hyderabad and later at AIMS, New Delhi, one of the most prestigious hospital in Delhi, in India. Dr. Verma did training in endocrine laboratory techniques from prestigious National Institute of Nutrition, ICMR. At present, he's operating as a professor, endocrine division, Department of Medication, Index Medical Faculty, and consultant endocrinologist specialist at various hospitals. He's a secretary of Polygene Disease Association of Republic of India at Indore. Sir, over to you.
Okay. Thank you for your kind words, Saurabh. And good morning, all dear friends. As the topic, I would be talking about the insulin therapies. We know this insulin in the management of diabetes has played a very important role for over 100 years. A couple of years back, we have celebrated 100 years of insulin, which has changed dramatically the life of our patients suffering from hyperglycemia, whether it is due to type 1 diabetes or type 2 diabetes mellitus. And any level, we know, any level of the hyperglycemia gets very well controlled without any side effects with the insulin therapy. So moving on, we know now that the necessity is the mother of all inventions. We are in an era where a continuous development of technology is there. We have seen the era from very simple machines to now an era where AI and robotics have taken a very significant place in our life, day-to-day life, not only the treatment part, but the overall. Few words about diabetes mellitus. This is nothing new. Yes, maybe for the last 3 or 4 decades, we hear a lot about diabetes explosion, especially in the Asian countries, because there is a dramatic change in the lifestyle of the Asian continent people. It is known 1500 BC Egyptian manuscripts, they have said 2 great emptying of urine. Sushruta in 500 AD and Charaka from India, they have identified 25 types of diabetes, including the modern day type 1 and type 2. So you can see 500 AD in India, the classification of diabetes was already there. Then 200 AD, the term diabetes was coined. 1674, Thomas William invents the term diabetes mellitus, which is different from the diabetes insipidus. I think we all know about that. And in 1776, Matthew Dobson discovers that this urine in a diabetic person is sweet due to excess of sugar. So this is, you can see the whole history of this diabetes mellitus. And again, the treatment has also evolved over the years. 1500 BC, opium, I don't know how it was used, but opium was used. Then 1706, John from Scotland told about low carbohydrate diet. Pere from France, again, he was talking about a hypocaloric diet. From France, Apollinaire, for treatment of diabetes, told to have sugar-free diet. Elliot Jocelyn in 1916 showed that how starvation or intermittent fasting can help in controlling the diabetes or hyperglycemia. But it was 1921 when Frederick Banting in Toronto showed that how insulin can control this hyperglycemia and change the whole scenario of that person. So I would say that insulin is one of the greatest milestones in the history of medicine. And if we see the older literature, we know that how people suffering from hyperglycemia were not even alive for a couple of months. Tens of millions of lives have been saved, and this is our extended thanks to Benting, Best, and Pulley, who discovered and used the insulin in treatment of hyperglycemia. So, some words from our Indian cinema also, the Bollywood, which again has got a rich history like insulin, where a good present and bright future is seen. 1922, isolation of insulin by Benting and Best was done. The first commercial insulin was available in 1923 for the people suffering from hyperglycemia. Monocompetent animal insulin preparations, which were ultra pure insulins, were in 1973. A recombinant human insulin came into market in 1980s, which reduced the allergic reactions happening due to bovine insulin. Then in late 90s and early 2000, we had modern insulin or insulin analogs like insulin detamers, a long-acting insulin or a basal insulin, and glargine, along with rapid-acting insulins like aspart, lispro, and gluvis. And now, from past couple of years, we have newer generation insulins like second generation basal insulins, degludec, glargine U300. Then we have ultra fast acting prandial insulins. We have the co-formulation of IDEC and aspart also. We have co-formulation of IDEC as basal and liraglutide for the postprandial sugar control. Now, again, available in market, latest, we have this glargine and lixisenatide co-formulation available. And inhaled insulin is also available in US, but It's not available in India. And then the story doesn't stop here. We have a lot of innovations in pipeline coming. In another couple of months, we would be having once weekly insulin. A single shot on Sunday would be sufficient. It will reduce the pricks, daily pricks for patients. Oral insulins, liver preferential insulin, glucose dependent insulin, where if the blood sugar increases, then only these insulins will work and will never cause hypoglycemias. Then we have beta cell replacements also. So you see the journey is constant innovation, constant betterment of insulin. Obviously, the insulin is in itself is a wonderful molecule, but then to improve the safety issues, the efficacy issues, and compliance also, we have these so many innovations with the insulin. And I will be talking briefly about these some advances of the insulin therapy. So here you can see these are some of the testimonies from patients over time. And this is quote from the latest review 2021. You can see here that how, I won't go in detail, but patients were really happy that this therapy has dramatically improved their life. So how this was discovered? January 11, 1922, Ed Jeffrey was injected with 7.5 mm of MacLeod's extract to Thompson with type 1 diabetes mellitus. The sugars were controlled, but there was a sterile abscess developed. And in January 23, again, J.B. Colib produced again a more refined extract and injected Thompson again so that it has got less chances of abscess development. The initial one of the patients, Elizabeth Evans, daughter of Charles Evans Hughes, governor of New York, later was America Secretary of State. She was having hyperglycemia. It was a nightmare for her. She was managing diabetes or hyperglycemia only with the diet. But then later, Banting, on request, agreed to see her and started insulin therapy for her. And her improvement was like a miracle in the community. And this news spread around the world like wildfire, and with desperate diabetics flocking to Toronto for the treatment of hyperglycemia. And these are the legacy of various companies, which insulin producing companies, which led to this effort. 1914 to 1972, Connaught Laboratories, a vital part of University of Toronto. 1923, Hess begins the industrial production of insulin at Frankfurt, Germany. Then it was bought by Merckx France, and it became Pasteur Merckx Connaught. And in 99, Pasteur Merckx parent company and Hess were part of the merger that led to the creation of Aventis. And in 2004 to 5, the creation of Sanofi Aventis. The historical Toronto site becomes Sanofi Pasteur. So this is about some of the companies who were the key producers of insulin over a century and in improving the various innovations. And these are the Nobel laureates associated with insulin discovery. You can see here 23, discovery of insulin, Benting and MacLeod. Then Frederick Sanger, 1958, structural formula of bovine insulin. 64, Dorothy Mary, discovery of structure of insulin. 77, Rosalind developed a radio immunoassay for measurement of insulin levels. So here you can see 5 people have received Nobel Award because of this wonder molecule insulin. And here, this was the clinical impact of insulin discovery in type 1 and type 2 diabetic patients. The life expectancy before the insulin discovery was just less than 3 years for type 1 diabetic patients. For type 2, there was a poor quality of life and obviously a shortened life expectancy of children and young adults due to various micro and macrovascular complications. But now, post-insulin discovery, the survival has increased progressively. There is almost near normal longevity and enhanced quality of life for our patients suffering from type 1 and type 2 diabetes. But still, we know that there is a initiation from patients and the doctor's side for the early initiation of insulin. But studies have shown that early initiation of insulin, intensive control of HbA1c just by 1% brings down the death related to diabetes by 21%, MI by 14%, statistically significant reduction in microvascular complication by 37%. So these are the data from the UKPDS trial, which is kind of landmark trial which shows early intensive control of blood sugar levels leads to reduction in micro and macrovascular complications. Then these are the insulin syringes. We know we now have 40 IU syringes also, which in India 40 and 100 both are available. 40 should be used for insulins which contain 40 units in 1 ml. And U100 insulins can be used for people who require higher dose of insulin. In this should be used with insulin vial which contains 100 IU per ml. So now, how far we have come? This was about the basics of insulin, the history of insulin. Here you can see various type of insulins. I won't go in detail, but here you can see these are the total duration of action, the peaks of various insulin, the inhaled insulin, the fast acting or rapid acting insulin, lispro and aspart. Then we have rapid, ultra rapid acting insulins. Then we have short acting, regular insulins. We have intermediate acting insulin, the long acting, the ultra long acting insulins also. So here you can see we have insulin which start working within a couple of minutes and stays in the body for 2 to 3 hours, ultra long acting, short acting insulins, and we have ultra long acting insulins also which stays in our body for almost 30 hours or more. So this is all due to some structural changes, deletions and addition in the basic insulin molecule, the A and B chains. I won't go in detail of this. This is the normal physiological insulin secretions. With every meal you see here, we have a short-lived, rapidly generated meal-related insulin peaks. So these are the typical peaks you can see with breakfast, lunch and dinner. And then there is a low steady basal insulin profile throughout 24 hours. So we have a basal insulin profile for 24 hours, and post meal we have, with each meal we have the rapid peaks. These are the types of insulin. I won't go in detail. We all know animal insulins were basically short acting, intermediate, and then biphasic. Were using it from 22 till early 80s. Then came human insulin. Again, they were short acting, intermediate acting, and biphasic, which was basically mixture of short and intermediate acting insulin. We had then the designer or insulin analogs in 1996, which were rapid acting insulin. They started working within 5 to 10 minutes compared to the earlier human or animal insulins, which required minimum 15-20 minutes or 30 minutes before the meal. We have long acting insulins, which are known as basal insulins like glargine and detemar. And now we have second generation basal insulins, which are quite ultra long acting, degludec and glargine U300. Then we have mixtures of these rapid and intermediate acting insulins like premixes and co-formulation. So what is a short acting insulin? Short acting insulin, whenever we require that they should be absorbed quickly and last only for a couple of hours. Then we have intermediate and long acting, where we want a slow absorption but a steady 24 hours control. Then we have a premix insulin, which is a combination of a short acting or an intermediate or long acting insulin, where we want a bit of faster absorption and a bit of longer duration. We can use these premix insulins. Now we have rapid acting insulins, which are absorbed rapidly within just 5 minutes. Their basic aim is to control the postprandial blood sugar level. Then we have first generation long acting insulin. They are very slowly absorbed and provide a low level of insulin in the body throughout the day and night. Second generation, very low absorption. They are designed to act more than 24 hours. So the flexibility is there. The person can take a single shot of insulin today morning and the other shot of insulin next day evening also. Usually it's not recommended, but that flexibility is there because the duration is more than 24 hours. Then we have premix and co-formulation of this rapid acting insulin and the long acting insulins. As per the patient's require, we can individualize. So this you can see and you can correlate it with our insulin. So this is the pharmacokinetics of various insulin profile. This is our normal insulin secretion post meal in a normal normoglycemic individual. And here you can see we have this insulin, which is a regular insulin, rapid acting insulin, which almost mimics the postprandial normal physiological increase in the insulin level. Then we have this, the regular insulin or the recombinant human insulin. Here you can see the problem is the peak doesn't cover the whole postprandial duration. And in fact, the duration is prolonged for 10 to 12 hours. So there may be in between hypoglycemias because of these regular insulins. Then we have this intermediate acting insulin, where we get a peak after 6 to 8 hours and the duration of action is maintained for at least 16 to 18 hours. But usually once a day is not sufficient with this NPH, and twice a day may have two very high peaks, which may lead to sudden hypoglycemias. But then came the long-acting decameron, which had a small peak, maintained a plateau for at least 8 to 10 hours, and then over 16 to 18 hours, the effect started waning. So this was a better long-acting insulin compared to NPH, but still it was not able to control for 24 hours. Then came first generation basal long-acting insulin, Glargine U100, which started working after 2 to 3 hours, and the plateau, the basal insulin levels without any fluctuation was maintained for 20 to 22 hours. So almost for the whole day, the blood sugar was steady, the insulin levels were steadily maintained. Then came even a better ultra long acting insulin. This glargine was compressed more for a still slower release and was made glargine U300 and degludec, which showed almost a straight line plateau insulin concentration in body without any peaks. So these are the latest, you can say, ultra long acting insulins available in the market. And then what are the advances in insulin delivery? Also, I have shown you earlier U40 and U100 insulin syringe, but those syringes had a lot of problem in using elderlies and children. So we have now over 2 decades the benefits of these insulin pen, which give more accurate dosing and are more convenient and easier than using these syringes. Obviously, this has improved the compliance because now the syringes are very small, accurate dosing, almost pain-free prick is there. So it is preferred by more patients, especially the elderly and the children. And these are some of the advantages of the newer insulin pens coming. LCD display to show the dosage setting also. Then the dosage settings change quickly and quite easily. And a safety button which automatically resets after the drug delivery so that no unused insulin is left behind or no extra insulin dosing is there. Then we have another innovation, these insulin pumps for delivery. It consists of basically a pump reservoir, a small battery operated pump, and a computer chip which controls the insulin delivery. We have these since long time, but now we have a lot of these insulin pumps available in market, which are almost automatic. They sense the insulin levels in the body and they calculate the doses and give it to the patients. In cases of where there is a progressive decline in blood sugar levels, they can sense this decline also and can stop or reduce the insulin, basal insulin secretion also, the delivery also. So these are some of the advantages of these newer pumps. They can be programmable. There are fewer hypos and hyperglycemias. More flexibility in lifestyle can be there, and a better quality of life is there. We have various insulin regimes used in our clinical practice. Once daily, long-acting basal insulin. Once, twice, or thrice daily, premix or co-formulation. We have basal plus and basal bolus insulins. 2, 3, or 4 insulins daily, and only mealtime blood sugar control rapid acting insulins are available. So we have this whole armamentarium of various types of insulin available for our type 2 diabetic patients so that we can individualize the therapy. It's not that one size fits all. These all latest insulins with their extra added benefit can be given to our patients to individualize the therapy or tailor-made the therapy, whichever is best suitable for the patient. So here you can see this is the representation of basal and premix insulin. I won't go in detail. So this is the basal insulin secretion. Here we have the basal insulin injection, which gives a flat profile compared to the basal human insulin, as I've shown earlier also. We have these premix insulins, which give again a peak and then they fall down. So you can see basal insulin, flat profile throughout 24 hours, premix insulin, before meal, twice or thrice we give them, but then there is a peak. So chances of hypos are there when the peak is there. And then the blood sugar level, when the level comes down of insulin, blood sugar may increase again. And this is rapid acting insulin. So here you can see that yes, with rapid acting insulin, the peaks are quite rapid. The PP control is quite efficient, and then they come back to normal also very fast. So in between meal, hypoglycemia doesn't happen. These are ultra rapid acting insulin. You can see big peaks to control postprandial blood sugar levels and lesser duration of action again. So these are all you can see the basic profiles of the latest insulins available. And here these are some, I would say one single slide here, biosimilar insulins. Nowadays, we have a lot of biosimilar insulins available in market. They are good to control the blood sugar levels, but then studies have shown that there is some problem in the biosimilar insulins, especially the safety pharmacology of these are limited. The reproduction mutagenicity, carcinogenicity here is not required. So we don't know these data about the biosimilar insulin, but yes, with innovator biologic molecules, I would say that definitely these have all been studied, and the FDA then only clear these innovator molecules compared to biosimilar insulins. So biosimilar medicines are not the same as generics, because generics have undergone a lot of safety data, whereas the biosimilar medicines, they have just shown the efficacy. Safety, still the data is quite less. Then talking about inhaled insulin, yes, we had inhaled insulin earlier in market, the Afrezza and Exubera. And these are the first insulin inhalation system. The relative bioavailability was just 20 to 30% compared with regular insulin. So a higher dose was required to control the blood sugar level. But then there was some restrictions. People with rhinorrhea were not able to use. People with COPD, the efficacy was less. Smokers, they had less response. More of allergic problems were there. But these were not, means they were not very successful in India. So we have new molecules, newer type of therapies still in pipeline. Maybe yes, we were not able to use the inhaled insulin in India properly, but we now have various other therapies, and we have miles to achieve in terms of hyperglycemia management, like cell therapy, various technologies, and disease modifying therapies also. So you can see here we have traveled a long journey. 1922, discovery of insulin and syringes. Then came the clinical monitoring, the insulin pumps, insulin pen, home monitoring of blood glucose. Then we had various devices, the open loop and closed loop automatic devices with the use of smart insulins. The sugar levels were programmed according to the patient's requirement. So here you can see we have traveled a long journey and still we have a lot of drugs and technologies in pipeline. And here one of the available latest innovations are the basal insulin for fasting sugar control and GLP-1 RA fixed ratio combination available, which have complementary and additive benefits to control the both fasting and postprandial blood sugar level with no increased risk of hypoglycemia and a moderate weight loss also can be seen. And we have now this Zoltofy and Salica available in India. Then we have this biochaperone rapid insulins. And this biochaperone forms a physical complex with rapid acting glycerol, protects it from enzymatic degradation and exerts a stabilizing and solubilizing effects, thereby increasing the absorption and bioavailability with accelerated action. So there is a faster rate of absorption, early insulin exposure, a higher peak concentration, and more rapid clearance. So it acts rapidly for a fixed small duration of time to control the postprandial peak, and there is a rapid clearance, so there is no chance of hypoglycemia. Then we have this insulin hyaluronidase formulation, which speeds up again the dispersion and absorption. So there is again the accelerated insulin exposure produce an ultra rapid action. So this is again more faster, ultra fast, works within in couple of minutes and stays only for a very short duration where we want a tighter and better postprandial sugar control. Then we have these smart insulins, which are glucose responsive formulations. You can see here, this is a micro needle patch applied to the skin. And these are hypoxia sensitive vesicles loaded with glucose oxidase and insulin in this patch. And on diffusion of glucose into this polymer, the glucose oxidase reacts with the glucose and consumes the total oxygen needed for the reaction, which triggers the vesicle degradation and release of the insulin in the body. So here you can see this is by glucose sensation. The diffusion of glucose into the polymer reacts with the glucose oxidase. Then accordingly, the insulin is released from the vesicle. So it will depend on the glucose level, how much the insulin is secreted from our endogenous vesicle. Then we would be getting very shortly once weekly insulin, basal insulin, single shot insulin once a week will take care of the whole basal insulin requirement. So lesser frequency of dosing and convenience. Only the disadvantage is, yes, if we are not sure, if we have given somebody a higher dose, then there is a risk of prolonged hypoglycemia is there. It may not be ideal for inpatient because it takes time to adjust the dose, and obviously large loading doses are required. So it's like somebody is requiring 10 units of second generation basal insulin, then he or she may require 70 units, single shot in a week. So it looks or it sounds quite a large amount, but again, this is just 10 into 7 we are making the total dose. But yes, there are some disadvantages also, can't be given to everybody. We have to take care. Then we have now these oral insulins coming, which have advantages like they have increased portal insulin concentration. They are non-invasive, patient-friendly, but are for short-acting insulin, maybe like a rapid-acting insulin. Disadvantages are the GI degradation and reduced bioavailability. So, and according to the patient's GI status, the absorption may fluctuate. So the insulin levels may also fluctuate. Then we have insulins available, which have advantages of increased portal insulin concentration, non-invasive, they're quite patient-friendly, and it bypasses the GI degradation, which is the problem with most of the protein molecules. Again, disadvantages are reduced bioavailability. So the response prediction would be quite less in these drugs. Nasal insulin, again, non-invasive, patient-friendly, bypasses GI degradation, but again the problem is bioavailability and local or nasal irritation. Then we have this also, the artificial pancreas also, where we have the continuous glucose monitoring inserted into the skin of the person. Then we have this monitoring receiver, which reads the graph and trends of the blood sugar level minute by minute and translates the reading from USB to the Bluetooth. And then there is a control algorithm device which reads these algorithms like in a smartphone, tablet, or PC, where the algorithm are analyzed and calculates the exact dose of insulin which is required. And then it is sent to the insulin pump. So the CAD communicates with the body worn insulin pump that automatically administers the correct insulin dose via a cannula inserted under the skin. So this is, you can see the artificial pancreas, the dose is calculated, their data is taken minute by minute, and the signals are then transmitted to the insulin pump to give the exact amount of the insulin for a fixed duration. So this is all I like to say today. The summary of insulin, long time total, you can see the very long journey from initial 1922. We started using short acting animal derived insulin, which had allergic reactions. We were not able to use it once or twice daily, required multiple shots. Then came biosynthetic human insulins, lesser allergic reactions. We came to basal insulin. Now we have rapid and ultra rapid acting insulin. We had earlier Exubera, the inhaled insulin, which was later withdrawn from the market. We then have pegylated insulins. We have recombinant insulin, uh, available long-acting insulin with the GLP-1 RAs also, and we have smarter insulins also in pipeline. So this is the whole summary of this wonderful molecule. Thank you.
Thank you, Dr. Verma, for enlightening us on the journey of insulin, what is available today, and how important it is. We have Dr. Chong with us. He is the chairman for CMAAO. He's joining us from Singapore. Over to you, Dr. Chong.
Morning,
Thank you
Dr.
very much. Thank you very much, Dr. Verma, for your wonderful description of all the insulin therapies. And it's quite enlightening to have a lecture on all these treatments and the new generations with regards to the insulin pump. I think CGMS has really helped a lot in the last few years of helping us becoming more aware of our blood sugars, glycemic variabilities, and that these actually cause a lot of problems for our body. So I think I'm just curious, the artificial pancreas you mentioned, is it all in one thing, or is all different CGMS hooked to, or they all talk to each other?
Yes, yes. Still, this has not come into commercial purpose, but yes, they have these different devices which are somehow connected to each other in a loop to make a better decision. So still, yes, I would say that we have multiple devices which are like kind of amalgamated together for better insulin delivery to the patient. But yes, it's still not a single device which is quite you can say convenient for patient.
Yeah, and I can imagine that even though when you monitor a blood sugar, you actually have a doctor telling the patient how much insulin to pump. But if you were to use an algorithm, that algorithm will have to be FDA approved and tested extensively, right? Before FDA will say, I allow you to use this algorithm to control the amount of insulin given based on the CGMS. I can imagine the FDA will be looking at this very, very carefully, because I mean, you can go hypo or various things can happen.
Very true.
Is that right?
Still, it's like we are still learning. We are still learning about that.
Yeah. That'll be amazing. But if they can have a very powerful algorithm that can actually work very well under real life condition, of course, the monitor got to be there, the pump's got to be working well. But if you imagine that you can have such a powerful algorithm, then you really realize the dream of an artificial pancreas.
True.
Because I think all our efforts to implant pancreatic cells in the body have all failed.
Yes. Correct. We have.
But diabetes continues to be a very massive problem in both the developed and the underdeveloped world. I mean, it's such a massive problem. I mean, don't know how we're going to reverse this.
I know, correct. It's very difficult. Lot of you also know. Lot of social media now. We have a lot of patients asking us about the diabetes reversal. I have also tried in a lot of my patients kind of diabetes remission. I advise most of them that diabetes reversal is not possible. No, but you know, a lot of social media advertisements and all, people they come to us with various type of diets, various type of therapies. So a lot of people are misguided. But yes, a lot of times I encourage my patients that yes, you adopt a good lifestyle. We give drugs which help you control sugars and weight loss also, and you may go in for a remission that may be sometimes temporary or a prolonged remission also.
Yeah, I think a remission always comes with a loss of 10 kilos or more.
Almost, yes.
So very, very difficult, unless they lose 10, 15 kilos. I mean, a remission is very, very tough. Anyway, do we have any more questions from the floor for Dr. Verma?
I don't think so.
Okay, if not,
sorry,
Dr. Verma.
John.
Oh, yes, Dr. Kuzi, yes.
Sorry, thank you for this. I just would quickly like to ask you a question. I couldn't find the button for raise my hand. Just want to know, is there still any place for working out your insulin dosages by using a slide scale? Because I still see that being used. And then only one other question is, if you are on your injectables, let's say you're type 2 diabetes, is it still necessary to take all the other oral treatment tablets with, or can you start to reduce them and up the dosage of your insulin? Thanks.
Yes, good morning. Yes, a very good practical points, madam. Definitely, I would say, yeah, we have are using now less of the sliding scale insulin. You can say the protocol, because what we believe is like sliding scale is a very crude form of controlling the blood sugar levels, or it is like after the insulin has increased, we are giving the sorry, the sugar has increased, we are giving the insulin dose. So it's like we are running behind the insulin level, sugar levels, but basically it should be a well calculated blood sugar level and insulin device. So sliding scale, we are preferring quite less in India nowadays, because we can get a pre-meal insulin levels and then give the blood sugar levels accordingly. And then we have now all these good insulin available in the market, which are quite helpful in controlling the blood sugar levels if we estimate a total daily requirement, which can be divided as 50% basal and 50% divided twice or thrice bolus insulin therapy. Then coming to the second point about the insulin therapy and the concomitant oral agents, if we can use it. Yes, I would say definitely if we are using insulin in our patients, we should avoid the insulin secretagogues. But we can continue metformin, we can continue a DPP4 or the newer SGLT2 inhibitors in our patient because of their extra added benefits, and obviously the you can see the their effect on the metabolic parameters. So I think both should be given in our patients, which should be well balanced.
Dr. Kuzi, was that, did it answer your question?
Yes, thank you so much. And it really answered my question. Thanks.
If there are no more questions from the floor, then we thank Dr. Verma today for a very educational discourse on insulins and the history of insulins. Amazing. I like your last chart at the end, where you have all the insulins over the decades. And we look forward to hearing from you another time about similar advances in insulin and hopefully an artificial pancreas.
Sure,
Thank
sure.
you very much, Dr. Verma.
Thank you. Thank you, Dr. Chang. Thank you, Dr. Saurabh Agrawalji. Thank you.
Thank you, Dr. Verma, for joining us. See you again. Everyone, see you again in next couple of weeks for the next session. Thank you.
Thank you. Okay.